Good afternoon, everyone. I'd like to welcome you all today to our webinar, which is entitled How Best to Treat and Manage Methamphetamine Use. Helen, you can click. Great. My name is Tina Netto, and I am now retired Chief Justice of the New Hampshire Superior Court. I still cover drug courts, so I've got my fingers in the mix. I will be moderating today's presentation, and here are some disclosures for us that we need you to take a look at. Obviously, this is our funding source, and our opinions contained in this document may not be theirs. We are doing this in conjunction with the New England Addiction Technology Transfer Center and the New England Association of Recovery Court Professionals. And here you'll see a description of what we do. We are funded by the Substance Use and Mental Health Services Administration. Our organization is designed to get all of this New England states together and make sure we're learning together and learning from each other. So we're happy to be able to present this webinar to you today. So I'm going to tell you a little bit about the presenters. We do have their bios contained in the invitation that you received, and probably most of you know who they are. They don't need much of an introduction, but we do have Dr. Brian Meyer, PhD and LCP. He's a clinical psychologist and the psychology program manager and supervisory psychologist for the community-based outpatient clinics at the Central Virginia VA healthcare system, and an assistant professor at the Department of Psychiatry and Psychology at Virginia Commonwealth University. And we also have Helen Harberts, who's been working on criminal justice since 1983. She's served as a prosecutor and a chief probation officer. As a probation officer, she started one of the first of our 40 DWI courts in the United States. She wrote the community supervision chapter of the National Drug Court Institution Judicial Bench Book and co-wrote the supervision guiding principles on DWI courts. So obviously you are all used to Zoom. Hopefully we are going to take your questions in the question and answer box, not in the chat box. The chat will be for including links and things like that. But we will be monitoring your question and answer box and answer them throughout the session. This webinar is being recorded, so you all will be muted with video turned off during the entire presentation. So as I said, the chat feature is for you to add in additional information. There are evaluations and certificates that you will get. Anyone who registered and attended the webinar will receive an email within the next 24 to 48 hours with that evaluation link, so please fill it out, and a certificate of completion containing the CEUs that you will receive from New England ATTC. And you can also find a recording of this webinar later on the ATT website and also on the New England Association of Recovery Courts website as well. So let me tell you just a little bit about what you're going to hear today. In this webinar, you're going to learn how to recognize the signs of methamphetamine use, overdose, and withdrawal. It will provide your court with specific strategies for managing those methamphetamine users' behaviors, the roles of different court team members, the most effective treatments for addiction with methamphetamine, and also it will guide you and your courts as methamphetamine use becomes more and more common among your participants. So we're hoping that the objectives you will achieve after this webinar are the ability to identify the signs of use, overdose, and withdrawal in your clients, that you will learn at least 3 strategies for using treatment court personnel to intervene in the behavior of those clients, and learn the evidence-based psychosocial treatments that are effective with methamphetamine users, and select one for your treatment providers to use. So that's what we hope to get out of this presentation for you here today. And I am going to monitor the chat, the question and answer, and I will now turn it over to Helen and Brian.
So I get to unmute. Brian's unmuted. Let's talk, Brian.
You can unmute, and now you can actually click.
And I should be able to check that out. We got a little disclaimer there because one of us works for the VA and one of us doesn't. Okay. There are no conflicts of interest by either of us. Okay. This is our stuff. Don't be running around with it. Okay. Who wants to talk about basics of methamphetamine? How cool is this? So you want to start or me, Brian?
You can start. It's okay.
So methamphetamine is a somewhat unique drug. It is long-lasting central nervous system stimulant, the CNS. The mechanism is very different from our other popular stimulant, cocaine, because it actually blocks reuptake and floods the synapses with excessive dopamine. So where cocaine has a very short life term and blocks reuptake, so when you use cocaine, you feel great. But here, you've got a massive flood of dopamine released from the brain that's locked into that synapse. It is neurotoxic. And therefore, we have a different type of damage to the brain when this drug is used. With treatment, always the key to treatment is retention, right? It's about dosage. And the key to methamphetamine retention is combined high-intensity MI, a lot of motivation work, because they suffer from anhedonia, and then reward-stimulated services. And that is why treatment courts work so well with people who use methamphetamine when they don't work quite as well for some of the other drugs, and why nothing else has worked real well for methamphetamine. So here's a chart. There's the difference. I'm going to put my cat down. Oscar, don't be a jerk. So methamphetamine, obviously a stimulant. Cocaine is a stimulant and a local anesthetic, often used for ear, nose, and throat surgery because it is a vasoconstrictor and it makes a very, very clean surgical field. Meth is man-made. There is no limit on how much you can make. Cocaine is plant-derived and based. Obviously, it therefore is seasonal and requires more processing and relies on Mother Nature. Smoking or ingesting methamphetamine produces a very long-lasting high. Cocaine does not. 50% of it leaves the body in 12 hours if it's meth, 1 hour if it's cocaine. So you can see the duration of the high and the amount of dopamine running around the body is extensive. It increases both the release and the reuptake, as opposed to just blocking the reuptake. It has very limited medical use, and they use it or a variation of it for ADHD, for narcolepsy, and I don't think anybody uses it for weight loss anymore, but it was in the past. And then again, cocaine is really just a local and surgical procedures. We take our meth in many forms. We smoke it by way of a pipe. It's a base. We can swallow it as a pill, very rare. We can snort it, not as effective, but works, and we can inject it. And so there are all sorts of routes, and each one, depending on the route, becomes more powerful and a faster high. Here is our short-term effects. Boy, do you freaking feel good in the beginning because that dopamine comes flooding out. There's an extremely intense high. There is increased wakefulness, overstimulation that will sometimes last for quite a while, which is actually one of the reasons why we have a lot of violence associated with this, because the body does like to rest, and this overrides that. Wakefulness, increased physical activity, a lot of punting, a lot of movement. Very fast breathing. It politely goofs up your heart, and part of it is a very rapid or irregular heartbeat, and it actually in the end wears hearts out. There is increased blood pressure, a lot of strokes involved with methamphetamine, and your body temperature goes way up. And so those are things that happen with the short-term effects of meth. And sadly, some of the stroke and heart attack stuff is becoming worse because the methamphetamine is becoming stronger. Also, meth mouths. When I first started my treatment court, I had a budget for a lot of things, but it never occurred to me to put a huge amount of money in a budget for buying choppers, because we had a lot of people who had very bad staph infections in their mouths, lost their teeth, were in excruciating pain, and it is very, very difficult for them to get self-esteem or anything going when their mouth is as bad as it is. The extreme weight loss, malnutrition is common, intense itching, which leads to sores, huge spike in anxiety, and then actual fundamental changes in brain structure and function, which happen. They're confused initially, and frankly, long-term, there's some memory loss that exists. You can build around it, but it exists. Insomnia comes on, the violence, which is something that we saw very much. I'm absolutely convinced that this is the only drug that actually causes violence as opposed to gives permission to violence. Paranoia, which lasts substantially. Hallucinations, both auditory and visual, are not unusual. Psychosis, 47%?
Can I tell a quick story here?
Go.
So one of my patients who had an addiction to meth, he one day calls me up and he says, I'm really high and I'm seeing things. And I said, what are you seeing? And he's a veteran. And he says, I'm seeing the ghosts of all the people I killed. And he said that they were also talking to him and that they were telling him to kill himself. And so what I had to do was to safely somehow get him from where he was into the hospital as fast as possible. I was able to get his grandparents to drive him to the hospital, and he was freaking out. And in the emergency room, they knew what to do, but then they put him up on a medical unit. And on this medical unit, they had no idea what to do with this guy. And, he's in this 12-hour block. He's actually lasted longer because he took a couple of milligrams of meth, which is enough to kill most people. And I literally, when you work with people, and they may not know, I'm not a psychiatrist. I don't get to prescribe medication. And they literally did not know what to do with this guy. And I said, well, look, I am not practicing out of my practice. However, I do know that when I have seen psychiatrists managing this before, what they typically do is they give them a good dose of Haldol. And then the people calm down and they're not so agitated. And after a while, the hallucinations go away. And so, in fact, they did decide to give the Haldol. And lo and behold, he got much better on a temporary basis. There you go. That's the psychosis and hallucination.
Yeah, we've had people misinterpret signals and suddenly become violent in the field or in the office. We've had them experience very sudden auditory hallucinations during drug testing. And it terrifies them because they don't know what's real and what's not. And it often happens after they've done fairly well at treatment for a while, and it will flash back on them, and it terrifies them. So one of the more important things is to tell them this may happen to you and it is normal, and repeat that so that if it does happen to them, they know it's normal and they don't go bananas on us. Obviously, risk of a lot of transmission of diseases, HIV, hepatitis B, C, STDs, because it's also fundamentally a sex drug, and we get a lot of STDs transmitted, so we need to make sure we're taking care of medical issues. Severe emotional problems, severe cognitive problems, especially in the beginning, and risk of developing Parkinson's disease because it burns the dopamine so much. And so you'll see some tremors and things with advanced long-term. Obviously, inflammation of the heart, damaged blood vessels if you're injecting, abscesses, stroke, birth defects, dental disease. We already had that. The real point here is to make sure that we're taking a look at medical care as well, because there are a lot of things going on when we get some of these people in. Their trouble is deeper than just the drug. Many of them are really physically sick when they first come to us, and their brains have been sharply insulted. And I think it's you cannot overstate the shame and the hopelessness that they have, the sense that nothing works, that they've tried to quit a million times and it never worked. And with methamphetamine, of course, the up is so high, the high is so high that when they crash, it is deeper, right? deeper below baseline. So when they come back to use again, they're really just trying to feel less bad. It's never again about feeling good. And it is a grinding sense of hopelessness and anhedonia that takes over for them. And that's why you've got to focus so much on engagement, because they're lost and they can't remember and they feel like roadkill. And they're so sick. And you have to pay real close attention, because if they indicate that they're feeling suicidal, they will cash that check very fast. So believe them. You want to do this part?
Sure. So how do you know when you're looking at these people? And here are some of the signs that, so that you can recognize it. Now, not all of them will happen necessarily in your court, and you can't really see the irregular heart rate, but you can see people being really agitated. You can see how fast their breathing is. It's very short, sharp breathing rather than long intake breathing. They have a very hard time sitting still because, they got all that dopamine racing everywhere, and dopamine, and it's a stimulant, okay? And sometimes they'll turn bright red for you because they're overheating. Literally, their body is overheating. And so these are all signs that you can recognize, and you can see them whenever you're meeting with one of these people. Even if you're meeting with them over video, you can see this kind of stuff. And then you also, and it is important to learn these signs. Okay, that's meth use. There's also meth overdose, okay? A typical dose of meth is probably about half a milligram. A high dose of it is about a milligram. I mean, this is not much, okay? It's very, very little. 2 milligrams is generally enough to kill. I've seen people use it to try to commit suicide by taking 2 milligrams because they're so desperate and they're so hopeless and they just want it all to stop. And yet they're still addicted. So they use the addiction as a way of killing themselves. But, here you go. If somebody is overdosing, they've got that red face, hot look. They can be a little sweaty. They may complain about headaches or chest aches. They don't walk very well, okay? When you're that overstimulated, your balance starts to go. They may have some difficulty breathing, and if they do, again, it's these short, sharp breaths that they take. We talked about the psychosis. They feel panicky or agitated because what is this? They're hyperstimulated. This isn't a stimulant. This is a hyperstimulant. There is nothing else like it out there. Over time, they start getting really confused and disoriented, and they don't know what they're doing. I had a veteran once call me up and tell me that he was going to kill himself, and he literally could not tell me why or what, but he was high on meth at the time. I had to send police out there for him. Tremors, spasms, jerky movements, again, all signs of too much stimulation. And then there's withdrawal, and withdrawal looks a little different, okay? Because one is when you got way too much of this stuff in you, and the other is when you got way too little. And people crash from meth, okay? Please understand the meth crash is a giant thing. They get depressed, they get exhausted because, they've been on overdrive for so long. And 12 hours of overdrive is enough to wear anybody out. And so then you can see other things happening. You can still get the paranoia, the suicidal thoughts can erupt from all of that. I know this is a little bit hard to read because it's a little there, but they're exhausted and they want to go to sleep. All they want to do is lie down and go to sleep and not move because they have been so worn out. But because there's probably still some meth in their system, they can be agitated, they can be anxious, they can be panicky about things. The cravings certainly hit, and they hit very hard. And when you have this, part of what happens to these folks is they then begin to combine it with other drugs. And so sometimes what they will do to take themselves down from too much of a meth high is that they will use an opiate of some sort. And it is really important to find out if they're using any kind of opiate, because we now know that the number one cause of drug overdose deaths in this country is the combination of fentanyl and meth. If you're looking at drugs in order, fentanyl is involved in 70,000 of the 120,000 deaths last year. If you're looking at meth, it was 50,000. Meth used to be very low on these scales. Now it's number 2 in terms of overdose deaths. So it's a lot. And here you can see something about the devastating physical effects. That's a 21-year-old woman. And you can see what meth has done. This is the past year stuff. How much is it going on? And this is really the percentage of people 12 or older who are using meth. And what you can see is, when you're looking at this, is you can see these different blocks, and you get some use in the 12 or olders, is essentially in the middle. The 12 to 17s are at the bottom, and up above at the top is the 18 to 25-year-olds. That's when you're getting your peak use in those years. And to some extent, we are seeing a growth now in the 26 or older group. But it's a younger person's drug. You can see
Because there
here,
aren't many old people.
What's that?
Because there aren't many old people left. It wears your body out.
Yeah. Yeah.
I used to treat 65-year-old meth addicts. I don't see many now.
Yeah, you don't see many old people on this. And here you can see what I was saying, something about the meth overdose rates and how they have radically risen. And this is combined with the use of opioids, and particularly the rise of fentanyl, as we were stopping or cutting down on giving people medications that had opioids on them. And then they went and found fentanyl on the street.
And this top button, I just want to point out, I am from a source county. My county was pretty much controlled by bikers, Hells Angels and Misfits, and people who made a lot of meth. And now it's gone across the border, and there's big super labs. And the thing that's important to understand is look at the purity. Everybody talks about the various formulas, P2P and HI, and I've done all those methamphetamine manufacturing cases. The formula isn't the issue. The purity is the issue. This stuff is so strong that there are people in my county now that are just dropping dead pure methamphetamine. It is too strong for the human body. So the level of devastation and destruction that you're going to be treating is quite profound, because this stuff French fries a brain. And so everything that you're going to be doing in terms of contingency management, in terms of treatment courts, it's all going to have to be modified to address a drug that is so profoundly strong that the brain is functionally rewired for an extended period of time. And you're going to have to learn patience like you've never believed you could.
And that's for the parts of the brain that are still there, which we'll show you, because you literally get holes in your brain. Literally get holes.
It's kind of sad.
So
There's
here you see the overdose deaths through 2020, and you can see, I mean, it's very hard to see, but meth is a gray line, which really only begins to rise around 2015, but now it's number 2. Fentanyl is what has taken over since about 2014, which is number 1. And the combination of the two is really the thing that's killing people the most. So
the data is not good. We can agree on that.
Yeah.
It's discouraging data. That's what I call it. And check, going up. There's all y'all up there in the corner. There's Maine. I love Maine. Okay.
It's worth saying, by the way, wait, can you hold that one back for just a second? Meth, interestingly, unlike many other substances, has been a west to east growth. So it really started out where Helen is in California, and now it's much more in places on the east. And we are seeing much more these colors on this map keep changing. And what happens is there's more and more of this stuff in the East. And so if you don't have it, you're going to get it. If you only have a little of it, it's going to get worse.
Make sure it's on your drug testing panel,
Yes.
because you might be treating the wrong drugs. Yeah, once we shoved most of the labs across the border, it began to follow traditional tracking routes, and so it joined with the other drugs in distribution routes that were already common. And so just like the fentanyl, just like heroin, that now it's all the same route, all the same businesses distributing. And so the East Coast has become an equal opportunity methamphetamine market. Okay, so overdose deaths, everything's up. It is not equal in its distribution and death. Native Americans, Alaskan natives have the highest rates of meth use, more than non-Hispanic Caucasians. It is rising quickly among the African American community. There's a lot of people using it and a lot of people dying. And there it is, next gen, little speedball. Some of us are old enough to remember John Belushi and how that didn't work out, and it's not working out for many of our people. Anyway, there's the bottom line. This drug is very, very destructive. Yes, the slides will be available. So who wants to talk about methamphetamine in the brain? I'll help you. It's Brian.
I love to talk about brains. This is a NIDA slide, the National Institute of Drug Abuse. This is basically the pleasure pathway in the brain. The VTA is the ventrotegral area. That is the area of the brain where it makes connections with memories. And that is the area of the brain where you get cravings from. And meth cravings are some of the worst cravings there are. It is closely attached to the nucleus accumbens, which itself is often considered to be the pleasure center of the brain. That's where dopamine gets released the most. And what happens is it moves from there and it overtakes and floods the prefrontal cortex and it shuts down. And that means you stop thinking. And everybody has this system, okay? We have, the reason some drugs affect us is because we have these systems that are set up for these things. But this system is a survival system. Dopamine was released by eating good food, by having something nice to drink, by having sex with other people so that the species could survive, by love and nurture, especially of tiny human beings. And the problem is this overrides all of them, okay? So people don't eat, all right? And that's why they lose weight. So this is the entire system. Unfortunately, meth is not on this one, but it is very similar to the cocaine. And cocaine, heroin, and nicotine all are right at the pleasure center because of the dopamine explosion that you get when you use them.
And there is the fun chart.
Okay, this is the fun chart, okay? Because you can, what you have to do is look at what is on the left side for the effects of dopamine. And you can see that meth effects, okay, is up there at, in terms of what is the basal release, how much dopamine you normally have, is about 1,000 times more, okay? The next closest thing is cocaine, and it's only about 350 times more. So meth is like 3 times the amount of high that you're going to get in cocaine. Nicotine, heck, that's like nothing comparatively. That's 225. And ethanol, so when you're drinking, that's 200. I mean, this stuff gives you so much dopamine. It gives you more dopamine than anything else.
However, those of you who are allowing people that you're treating to continue smoking, take a look at the shape of that spike and check to see if maybe you might be reinforcing.
Next one.
It's not good. It actually causes death of the cells. That hence the phrase neurotoxic. It is one of the few drugs that is absolutely neurotoxic. And our cells just simply die. and additional brain cells in other brain regions also die, which is part of the reason why they have difficulty coming back as fast as other people that we treat. It erodes the mind, and this is a famous study from Paul Thompson at UCLA, and you can see loss in the emotion region, and reward and limbic system, and your memory. The hippocampus is severely compromised. And so if you actually look at this, it's going to be clear to you why we have difficulty engaging. We have difficulty with them remembering what to do, and why we have to work so hard in those specific areas as treatment does its work and magic and starts to rebuild some of the harmed pathways, because this is the key in to dealing with methamphetamine. You've got to rebuild an emotional system that's been destroyed. You've got to work a reward system very, very hard. And you've got to understand the memory is shot. So we used to all laugh, everybody says, oh, these aren't my pants. All the things that I heard that I thought were sort of funny when I was a first prosecutor, they're not funny, they were real. And I didn't understand. And so when you look at this emerging brain studies, you can actually see how we can do better, because the damage to the insult to the brain is so profound. There you go. Get them, Brian.
Holes in the brain, okay? Because what happens is it doesn't just kill the cells, it disintegrates the cells, okay? It's dissolving those cells. And so what happens is the gray matter that is on the outside, yeah, there's certain areas of the brain that it hits harder. Look at the one way over on the right. The front of the brain is on the right-hand side. This is where your thinking parts of your brain are. Look at where the holes are. They're on each side. That's called the dorsolateral prefrontal cortex. That is the part of your brain that is responsible for thinking, for logic. It's the Spock part of your brain. It's where you anticipate consequences. Oh, maybe this isn't so good for me. No, that's not happening because holes are burnt into it, okay? And that's really very worrisome, because you're literally losing the ability to use your logic. And it also burns out the parts that have to do with impulse control and assessment of risk. So you don't have the ability to do those things. So you can't really think about, oh, this is what I'm doing to myself.
Yeah. Oh, there you go. SPECT scan.
Yeah. So there you go. Lots of holes.
There's our guys. So when they come to you, they're sicker than most of the people with substance use disorders that you've worked with. And you've got to reset your clock and your skill set. Amotivational syndrome. Get them, Brian.
So you get these motivation, okay, is in the nucleus accumbens, okay, because that's where the dopamine is, and we're motivated by that to do things because it makes us feel good or excited. The problem is meth goes straight for the nucleus accumbens because it releases the dopamine, and therefore motivation to do anything else drops like a stone. And what you end up with is damage there that can last a couple of years, okay? A motivational syndrome for longer than 2 years can still be there. Now you've got to think about in your court, well, what is your time frame, okay? Because you're not going to have these folks motivated really for a couple of years. You have to stick with them for a long time. Their progress through the phases, it will take longer. It will take longer, and it's simply because of the brain damage that we're showing you.
And sometimes either in the Facebook group, Treatment Court Professionals, or on Rural Listserv or wherever I see it, people, the question comes up, should we take them back? If you've lost jurisdiction and you're not dealing with some of these issues, you need to take them back, because they may require 2 or 3 spins through your treatment modality in order to address all of the issues that these guys come to you, because we haven't even gotten to the full basket of parties that come. So here it is, working with meth users, extremely slow. very difficult engagement, more violations of probation. They're going to violate the rules of your treatment course, left, right, 16 ways from Sunday. You're going to get mad at them. You're going to need a lot of complex and comprehensive interventions, and there's no authorized medically assisted treatment to help them. They have very challenging medical issues, and they will pop up throughout the course of treatment. All of a sudden, something pops up. They have a tremendous drain on all your treatment resources because of the length of treatment and the amount of treatment they're going to require. And sometimes there's going to be starts and stops and stumbles and stuff like that. You're going to have more violence on your caseload. It is part and parcel of this drug. You're going to have drug endangered children cases, more elder abuse. You've got to make sure that your people are doing very good field services to monitor the recovery environment, because it is a little scary. And in practice, here's what that means to you. Oh my goodness. Diminished understanding, really imbalanced emotions, but often just flat. So we look at people and they look at their kids, and CPS would say they're not bonding with their child. They can't. It's not that they're not. It's not that they don't love your child. It is that they are suffering from anhedonia. They can't see their way out. They describe it as this terrible black hole. They're very, very sick. And you've got to keep your hand on them and keep encouraging them that it's going to get better and the things they're feeling are normal. Their physical capabilities and coordination is compromised in the beginning. Usually about 3 weeks in, we see people showing up with ace bandages and bruises because they've been stumbling, and that's because part of their brain is not quite back with us yet. They cannot remember stuff, so you've got to write everything down and repeat until you think you're going nuts. It's not you, it's that they can't remember. And we write everything down, and then we teach them to remember where to look for writing everything down. And they cannot manage sequential thought. Now, I want you to think about what your court orders are. They are all sequential. They are all high-end written. We give people 50,000 orders, and they can't remember any of it, and they immediately panic and run. Don't freak out. Go get them. Help them. Collateral violence and sexual misconduct is the rule with this drug. And officer safety, your probation team, whoever's going out there, you need to pay attention to what you're doing. The learning capacity is reduced.
Ascribing these things to intention. Sometimes people say,
no.
They ran, or, oh, they didn't come because they forgot. Oh, and they prescribe it to intention. But the problem is they don't have the motivational capacity to actually even develop that intention.
Oh, there's no decisional balance at all.
Yeah.
Yeah. It's like when my dad, when I was a kid and I'd get in trouble, and he'd say, "What were you thinking?" Assumes the fact not in evidence. I was not thinking, or I wouldn't have done it. And that's true with most of the people that we deal with who have this methamphetamine issue. They're running on impulse, and the decisions are non-existent. So practical application, which is what I'm after, they're going to be slower to recovery. You need to be really patient. There are delays in treatment impact. There are delays in engagement. You got to push MI and engagement all the time, and very simple messages. And literally, I can't tell you how many times all I said to people was, show up. I just need you to show up. If you're scared, show up. If you've used, show up. If you're angry, show up. If things seems like the world is going to end right now, show up. And what do I need you to do? And I'd make them repeat it back, because the thing that's most important is show up. I can't treat people who don't show up or who are dead. Brief, frequent, and supportive contacts, always with a smile, always with engagement, always working to instill hope. Instill hope. Instill hope. The team needs to allow people to goof. Trial and error. They're going to make mistakes. They're going to do things that, they're not necessarily criminal thinking errors. They're just the brain, the software isn't hooked up, and they're going to goof. And it's cognitive impairment. And the issue is really not malice. It is the depth of the brain insult, and you just got to pick them up, dust off their jeans, and say, this happens. Keep going. It's okay. We got you. And keep going. And don't get mad. Just get effective. In practice, There it is. Go slowly and repeat. Significant repeated episodes of anxiety, which will terrify them too. And you've got to tell them that's normal in advance. They have confused thinking that will come on and go off. So you're working with somebody and you think they got it, and then all of a sudden, boink. And the chart that Brian put up about pause, post-acute withdrawal syndrome, ours was usually about 5 months in, just sometimes 7. And you got to warn them it's coming, because they think they've certainly turned the corner, and then wham, it comes up. And, so you pick up your contacts, you talk to them more, you say, this is normal, don't worry about it. Your brain is actually good. Your brain is restructuring, but it's going to feel horrifying to you. Short-term memory problems, repeat, write down, remind where to look. Again, suicide is real here. Some will have punding and auditory. They'll have, you can see them picking at nothing, and they'll have little scabs, and those can lead to infections. That's not everybody, but it is a significant percentage. You'll see them sort of, and it's a hallucination that occurs just under their skin, and they're banged up. Understanding the drug. You want to talk about understanding the drug, Brian?
Sure.
How cool is it?
It's really bad. I mean, we've got these memory deficits, we've got depression, we've got energy problems, confusion, hallucinations. Those are normative, okay? Try to imagine that you're getting some mix and flavor of psychosis, dementia, depression, all at the same time, okay? Because
on high speed.
That's actually what's happened. And so you have to infinitely, as Helen repeats, patience. You got to be really patient. You got to repeat, and you must engage. And it is really hard sometimes, because you may get mad at them, as Helen said. You may be really frustrated with them. That is part of the process. We have to be welcoming to them, and we have to catch them when they fall. And they will fall many times, and they will get banged up, and we have to catch them and help them stand up again.
Again.
Engage.
Yeah, engage. Accountability, certainty of detection. You've got to use your best top drawer behavior modification. Find out what they're doing, react immediately, catch them doing right, focus. Always remember that this disease will live. As a prosecutor, the phrase lying in wait. When I did a death penalty case, one of the criteria was lying in wait. And I will tell you that perfectly describes this disease. It will lay in wait your entire life to come back. And when I first engaged in this, I underestimated the power of this disease. And that's a big mistake. This thing is incredibly strong. Okay, it's cut with fentanyl. We already talked about that, so we're not going to waste your time on that. Here's, this is one of the things I just tell you as a practitioner. I was always struck by the lack of hope when these people came in, that they were just absolutely devastated and were flat and had no hope that anything would work. They tried to quit 1 million times and couldn't. And then they come into a courtroom of a bunch of us going, yay, welcome to drug court. And they're like, oh, man. The sense that recovery is not possible is pervasive with this group. It is futile to try. The level of their pain is extraordinary. And the level of trauma and things they've gone through when it starts to come out really throws a horseshoe in everything. And the other thing is their incredible courage. Because I work regularly with people who are in full, robust recovery from acute methamphetamine disease, and they are fine, and they are fine people, and there is a way out. And it takes a lot of courage and a lot of stamina, and you just got to keep them going until all the work that everybody's doing pays off. You're rebuilding a brain that has been acutely insulted, just like a stroke. It's really no different, except you maximize engagement. You have to teach them pro-social activity, even though they won't want to. They want to stay home and cry or hide under their covers and not come out. That's that exhaustion part, but we got to keep them going. And for heaven's sakes, use the power of placebo. You get a 15% bounce if you use placebo. So the minute they come in, I say, welcome to the treatment court. This is the greatest thing since sliced bread. You may have tried to quit a million times. This is a place you're going to be able to. And I just sell it. And I smiled a lot. And that's weird for a prosecutor. So bottom line, methamphetamine abusers recover very slowly, and you need to expect them to be with you longer and to have setbacks. Now, the sad part is I observed they were aware that they were taking longer to get better than other people who were using other drugs. And they are aware that they're not doing as well as non-meth people in group, which is why, if possible, you want to treat your meth people all together using Matrix. It really makes a difference because they sit there, and as we all know, there's sort of a hierarchy of I use this and you're not as good as me because I use this. And one of the things my methamphetamine people for years, they hated heroin addicts, right? But the heroin addicts that I was treating would get better faster. And then the meth guys would go, oh man, the scum of the earth is getting better faster than me. This is hopeless. And then they go out and self-sabotage. And you've got to kind of be aware that that's going on. They know that they're not getting well as fast as other people. So positive tests, don't freak out. Positive tests aren't a surprise, especially in the first two phases. Setbacks occur, we just try again. Never give up on them unless program integrity is threatened. I expect them to try to self-sabotage repeatedly. Going to be lots of IOP and sober living demands. You will find if you use residential that there is a lot of immediate lapse upon release or happy feet and they run. Have evidence-based response and timeline in place for these people. It's not the same as an alcohol or opioid timeline. It's different. And make sure you give them hope and do not give up. You want me to do this part?
You're the prosecutor, so
I'm kind of a prosecutor type person. Let's talk about that. Prosecutors on your team should be instilling hope, and they should be working on engagement and education. And that's a little weird for us, but trust me, it works. And also you have to remind prosecutors to smile. That's not how we're trained. We don't smile at people who have been ripping up our community. But in this setting, smile. Okay, listen to treatment. It's hard for people who think they know everything to listen to treatment. Job one in a treatment court is to listen for treatment. We created an entire system of treatment courts, and then we didn't listen to treatment. That was not very smart. So they got to listen to treatment because their opinions are just that. They're useless and they're uninformed. We need to let probation and treatment run the show. They're the ones who are doing the one-on-one services. Our job is to protect public safety and to protect due process. Basically, we're lawyers and we're there to practice law. We're not there to practice treatment because we're not licensed treatment professionals. But the other thing is, prosecutors often start pounding the table too early to throw people out. Don't get your power up. Be quiet. Don't give up on these people. In fact, you should be the one insisting they stay because the data shows us that this is the best possible outcome for anybody who has a moderate to severe methamphetamine use disorder combined with high needs. So if you're interested as a prosecutor in reducing crime in your community, this is the place. And if you throw people out, you just make it freaking worse. Who thinks we should make things worse? I don't. That's not smart. Sometimes your public defender might need a little protection because they need a continuance because their guy's completely altered and they can't get him to talk. And if the public defender says, I need more time, the guy's paranoid. He screams, you're trying to undo me? No. So my public defender would sort of give me a look and I'd just sort of say, Your Honor, I'm sorry, I don't have the right paperwork. Can we continue this a week? That gets the public defender out of trouble with his client, maximizes his engagement. They already hate the prosecutor, so it don't matter. However it is that you need to protect your team and get things going and keep people engaged and move the law as much as they can to facilitate treatment and probation, what they need to do with these people. That's all you need to do. If I need to move fast, I can. If I need to slow things down, I can. That's the power of a prosecutor. Also, smiling. Work on the smiling. It's unnatural. Defense attorneys, talk with people. Talk with people, talk with people. And then repetition. Same thing. Use metaphors, tell stories. This is actually from the defense attorney I practiced with for well over a decade. Build a reputation so they trust you. That takes time. Tell people how to fail. Tell people how to succeed. And then again, show up, show up, show up. Show up, show up, show up. If somebody fails to appear that day, a letter and a phone call leaves the defense attorney's desk saying, it's important for you to show up. Don't run. Come to us. We'll take care of it, right? Immediately reach out, because when they run, then they think, oh my God, and then they go on a run. Probation support. Assess often. They are changing. Identify the criminal thinking issues and criminogenic needs issues. Start focusing on MRT. You need to focus on the dosage of contact with probation. Increase dosage when they need more support, like when they're hitting post-acute withdrawal syndrome. You want to address sequential case management in order of assessment and importance. Here's the thing our treatment courts do. We sometimes overwhelm people. And I'm telling you right now, with methamphetamine, show up, try hard, and tell the truth is overwhelming. So you got to make sure that we don't love these people to death. They do not have the mental, literally the brain capacity to do some of the things we ask them to do. So you got to slow it down and smart it up, and don't overwhelm people. But before they leave, they have to have prosocial habilitation, which is criminal thinking. And you do that before you do adaptive habilitation, which is how to live in this world and address all those assessment-driven complementary services. Proactive field services are important here. They support recovery, but they also address a lot of intermediate incentives and sanctions issue to instill hope, instill hope, instill hope. Conduct drug testing, do not reduce it until the very end. And then probation should be, or your supervision should be, in constant communication with treatment. The left hand and the right hand have got to know what both are doing and seeing all the time, because this can get away from you really quickly. Also, sometimes in the field, we discover those little hidden issues. Gang membership, they know we're really fussy about that, so they try not to mention it. You go in the house and it's all ganged up. That's something that's a case management issue, and you need to know about it. Domestic violence, very common in these homes. Child abuse, child neglect, elder abuse, very common. Financial abuse, acute mental illness, really bad poverty, no food, no shelter, and then educational challenges. So those are the things we look for when we're out in the field, and we need to assess them, but we also need to visually assess them to see what is going on when we show up. There are problems with childcare. They don't know that they should have childcare, so they don't have a problem if you ask them, but it's a problem. Parenting deficits. Sometimes people with developmental disabilities, you see that more in the home than if they're doing maximum performance they can. Unsafe housing, lack of reliable transportation, no problem-solving skills. And then secrecy and fear over auditory and visual hallucinations, really common. It'll fade if we just tell them. So here's our tools. Another toolbox. Encourage and support, repeat everything, reaffirm everything, remind them of every next contact, repeat again, repeat consistent messages that show up, require repeat backs to try to drive it into the brain, write it down, reaffirm it, tell them where to look for it, and keep everything simple. Build a foundation, don't push too fast. Add tasks as they get a capable foundation. As they show competency in certain areas, then you can add one more. Constantly assessing for stages of change, because you want to talk about something that can move fast with this group, it's the stages of change. Boom, they're motivated and then they're not. Focus on hope and every tiny step of success, because they won't see it and you need to. And you've got to increase your frequency of instilling hope and incentives sharply. Want to go? Look at all this cool stuff.
Lots of cool stuff that you have to do in assistance. This is a bigger package than the usual drug court package in terms of what you have to do. Because it's not just that we're doing community supervision on these people. We have to increase the number of times that we see them, because remember, short contacts, 20 to 30 minutes are better than, 3 short contacts are far better, that take up an hour are better than one hour contact. I mean, they're not going to, you sit with them for an hour, they're not going to take it all in. They do not have the capacity to do it. This is a capacity issue. And the capacity is happening both at the cortical level, outside on the top of their brains, the thinking parts, and it's happening on the limbic level, which is the emotional and attachment parts of the brain. It gets into all of that kind of stuff. You got to have baby steps, do little things, give them reminder slips, give them 2 sets of orders, give them signs to put up. Give them gold stars and stickers. Give them candy bars, I mean, okay, that'll give them a little bit of dopamine right there, good chocolate, that'll do it. 12-step materials, you got to have all of those 12-step materials available for them. Write down everything. Do not say things orally by itself. You must write everything down. You must make sure they have it. You must ask them where they're going to put it, because they have to think about where to put it in order to think about where to find it. You want to be giving them points. We're going to talk about contingency management. It's good to have anything that basically makes them feel better. Can you do all this stuff? Probably not. You got to find community partners. You need vitamins, vitamins, and vitamins. You need your health educators. You need your food stores. They have nutrition classes. You can have people go to banks for money management. You need physicians in the community. You need people from the faith community. You need all these, and everybody's got to incentivize, because you're trying to override that dopamine stuff.
So
back to you.
We can pay attention to supervision, but you guys can look at this. This stuff is all going to come out in treatment. I think the thing that's really important is, if you got methamphetamine, you've got trauma. It's 1-to-1. It is 1-to-1. And so it's going to come out. It's going to come out a little later, and it's going to be gnarly. And you need to also be careful about the people in the home and pay attention, because there'll often be delayed disclosure there. We've got to address those issues as they come up. That's actually my county right there. That was from one of my cases. And if you're not getting out of your office, you're not going to find this. That was a bunch of people. That was their recovery environment. Does it look good to you? Didn't look good to me. Look at the home. Child neglect happens. The thing on the right is actually an active methamphetamine lab in a refrigerator in a home in my county. And if you know what you're looking at, you would look at the Pepsi bottle on the top right with the black hose going out. That is actually a generator that is making methamphetamine. And the soda bottle with the label off it with the hole in the top, that is methamphetamine being made. And then the car jar on the top left is a bilayered solution full of acids. And if you're a child in this home and you're hungry, you might come in here and try to pick something up, or something that looks right and has a familiar label, and it is toxic. And in fact, the foil that's on that bottom shelf on the right contained chicken, and we bench tested it, and it tested positive for methamphetamine. So you need to pay attention to what's going on in the community. We need to make sure we get that stuff forward. We wanted to make sure we're looking at the ASAM environment carefully, and that your people are very aware of officer safety issues. You got to stay alert, and you need nights and weekends, right? Testing, self-report is no good. Oops. Okay, focus on forcing treatment, coerced treatment. Drug courts are best, which is why treatment courts work best with methamphetamine. Repeating proximal goal, incentivize, do what works. Here's the treatment. Fire up, Ryan.
All right, so here we go. Look, it's going to be a long time. You've got to expect that it's going to come in phases. It's got to be more intense. Brief is always better, okay? Residential treatment, no, we're not going to stick these people in for 6 months of residential treatment. That is not going to do it. You stabilize them. You put them in the hospital for 5 or 10 days, and then 3 to 5 clinic contacts per week for 90 days, okay? If you're a psychotherapist, you see them for 20 to 30 minutes, 2 to 3 times a week. You cannot be seeing somebody on a weekly basis. It is the frequency of dosage that matters, not the amount of the dosage when you're thinking about treatment, okay? It's frequency, frequency, frequency. You have to really aggressively reach out to them. People are always wanting to run. Remember, their bodies are agitated. They got to move. I mean, this just goes with it. You've got to have your analysis happening constantly, basically. As Helen said, nights and weekends are really important to take those things. Make sure you attend. If somebody shows up, there's a reward for that. If somebody gets a clean UA, there's a reward for that. Somebody shows up to treatment, there's a reward for that. Reward every single step in you got to reward micro behavior, okay? Medications, I'm sorry, we don't have a whole lot of good stuff. We can help the depression that they get when they're crashing with some stuff. But, it just isn't going to be the answer, unfortunately. We need to do CBT, but we do CBT light at the beginning, okay? They do not have the cognitive stuff there. They can't remember, and they're restless. So again, short times. We have to work engagement strategies through motivational interviewing and motivational enhancement therapy, and reminders, okay? Visual aids, any kind of brain exercise. Have them do puzzles, have them do crosswords, make them play cards, learn new skills. If they can play music, it doesn't matter what it is, get them to do brain exercise, things that have complication in it, so they build new brain pathways. Why? Because the pathways have been dissolved. Think about a road where parts of the road have fallen off. You have to rebuild every single one of those, and things that have some complexity to them, build them faster. It's not the simplicity, it's the complexity.
Yeah, in our probation waiting room, we had clipboards with mazes and puzzles that were downloaded from teacher websites. And if we went out and saw you doing those, you got called first, which encouraged everybody to start doing them, because we are actually simply, while you're sitting there, trying to rebuild pathways in the brain and develop skill sets, because, it seems sort of childish, but it wasn't. Crosswords, puzzles, things like that. And then you expand on that as they become more stable. But it's fascinating. Actually, the exercise that is one of the ones that's recognized to do very well with people who use methamphetamine is table tennis, ping pong. No pharmacotherapy. We've tried. We get there's clearly some benefit with naltrexone, but it's gender specific, and it's not repeating itself as much as reliably as one would expect for something to be FDA approved. So they're still working on it. Naltrexone may be considered by a physician, especially if they're using opioids. It's approved for opioids and alcohol. Benzodiazepine is obviously very time limited. You don't want to get a combination going there. And here you go. Fire up, Brian.
Okay, so here you go. We've been mentioning these things. These are the 4 treatments you must have in your catchment area. You have to be able to use all of these treatments, and they do it at different times. You need contingency management. Why? Because you need to reinforce all the small behaviors. You need cognitive behavioral therapy, rebuild the brain. Motivational interviewing, you have to rebuild the motivational center of the brain. And the matrix model is great because it's comprehensive. I'm going to talk about each of these a little more. Contingency management, there's the rat pressing the bar. As long as we get them to press the right bar, show up, show up, show up, okay, you get rewarded for those things, okay? You get a drug-free, you show up for your urine drug screen, you get a ticket there. If your drug screen is negative, you get another ticket there. And when you have contingency management rewards, there's a variable reinforcement schedule that has been set up, and where you put 500 tickets or 250 tickets or 500 tickets into a fishbowl. And there is an exact percentage of how many things need to be things like complimenting somebody, saying, you did great. That is a reward. But, you're also going to have a prize cabinet, literally, of things they can do. And in the prize cabinet, there are lower levels, and you can pay for those. This is Chuck E. Cheese. It's exactly what Chuck E. Cheese does. You have a Chuck E. Cheese prize cabinet from lower to higher. And people, if they can manage to save up, and it's very hard for them to save up, but over time, when they get better, they're going to save up to get the bigger rewards, because they can withhold the impulsivity. They can stop the impulse just to spend it right away. It does work. Here's the data for it. What you can see is contingency management compared to treatment as usual. The success rates for abstinence, which is the lower one, and for having negative drug screens, which is the higher one, you can see is better with contingency management. There have been multiple literature reviews and meta-analyses in the last 5 years on these things, and it is showing better outcomes than any other behavioral interventions for methamphetamine.
Yeah, just double it up. With methamphetamine, just it's kind of like hunting for truffles in the forest. You got to look for them, and when you find them, it's a big party. So you got to look for anything that they do that's correct and reinforce it right now, right now, right now, right now.
If you do not have contingency management, it ain't going to work, folks.
Nope.
You have to have something else that stimulates the dopamine. And the chances, gambling is a variable reinforcement schedule. So is contingency management. And people can develop an addiction, as we know, to gambling. But the reason is they get motivated. They get caught in it. So we're trying to get them motivated to get more tickets. And if they get more tickets, they will get more rewards. Cognitive behavioral therapy, yes, we're trying to get them to begin to think about things again. We're trying to get them to practice these things in their heads. They need to know, understand, there's a relationship between how they think, what they feel, and how they act. Those are always there. And so we are, especially at the beginning parts of treatment, heavy on CBT. Motivational interviewing, we have to be heavy on this throughout, okay? Basically, what we are doing is we are practicing reflective listening, not active listening. Reflective listening means we summarize what we heard them say. It's empathic. We always have to be thinking about how they're feeling and what they're thinking at a particular moment. It is, when somebody resists in what we're saying, we just roll with that, okay? And so we don't argue. There's no argument with them. And especially at the beginning, you are not going to win an argument. If you're in an argument with somebody who's using meth, you have already lost at that point. We have to get them to begin to feel like they can be in control. We can't take the control away. They don't have any control, so we help guide them towards it, but we have to support that kind of thing. Next, please. It is effective, okay? Even in brief amounts, it can help reduce the amount of meth a client uses in 1 to 4 sessions. Seriously, you think we can't do something with a small amount? Yes, we can. So motivational interviewing better be right up there up front, right? Because we want to start reducing the amount that they're using, whether it's the amount in milligrams or whether it's the frequency with which they're doing it. We want to reduce, and we're going to reinforce that through our motivational interviewing. The matrix model is something that sort of combines all of these things, okay? You can see there's cognitive behavioral therapy, motivational interviewing, contingency management. You can also see there's part of it that has to do with the 12-step facilitation. And when we can, and it isn't always possible, we try to bring in the family, okay? It is a multimodal set. So what are we trying to do in the matrix model? We're trying to do it all. That's right. And so you have to be able to have each of these components as part of your toolbox. If you do not have any of these 5 components, you need to have them. And you can see that the results improve, and this is what Helen was saying, with drug court supervision, okay? Drug court supervision really is the other part of this that really needs to be, thought of as an intervention. By itself, drug court supervision is an intervention. We give them incentives, we give them sanctions. That's an intervention. Here are the components there. These are all the different kinds of treatments. Look at how many different things they're getting. Remember, these people, they're not very social, okay? And to the extent that they're social, they're using it with somebody else. And so what are we doing? We're giving them chances. We give them group after group after group: early recovery, relapse prevention, family education, social support, 12-step, group. lots of other things. We've talked about some of these kinds of things, and so I'm not going to recite them. Do not start MRT at the beginning. A moral recognition therapy needs to be started midway through. Why? You have to build them back up again in their brains before they can begin to think about moral things. That's a higher level brain function, okay? And they're missing lower level brain functions, much less higher ones. It is a good idea to, as Helen said, a lot of them, all of them have trauma. A lot of them have childhood trauma. And you can do concurrent trauma-focused treatment, but again, part way through. You can't do that at the beginning. They can't handle that stuff. It's too much for them at the beginning. And see, you can see in their brains, by the way, even when they have stopped, okay? And they have stopped for 5 years, there are still problems we can see 5 years out. This is why, as Helen said, let them back in. These people, you need to be really open to letting them back to doing multiple go-rounds. Think of it like a child. A child has a certain set of understandings when they're 3, but when they're 8, they understand a different way. And when they're 13, they understand a different way.
No, when they're 13, they begin to not understand a damn thing.
Well, there's that. And what we've got to really think about is this is what we're doing with their brain. I mean, you know, they've got holes in their brain. We got to rebuild them. And therefore, it's going to be a phasic process. Really, it is fine to repeat. And in fact, in some ways, I would encourage you to have these people come back. Next.
My treatment court population was always very close to 90% methamphetamine. And I will tell you that 90% of the women plus reported sexual assault, and about 75% of the men. And so if you don't have trauma screens and assessments and seeking safety rolling in your programs, you need to get that.
Absolutely.
I can't think of a polite way to put that. You need to get that.
By the way, you know, when you're dealing with trauma, trauma also shuts down the same part of the brain, the prefrontal cortex on the sides, the dorsolateral parts, stops the thinking.
Yeah, our big secrets usually came out about 8 months in.
Yeah.
You could see it sort of would rumble like a volcano. You could see the tremors, and people would start to get sort of different and hinky. And I'd look at treatment, I say, something going on here. And they'd say, oh yeah, Helen's about to get close to something very difficult. And that was code for we're going to have a wild ride for a couple of months while the trauma comes out and gets processed, because you could sort of feel it build in people, and then boom, and then there's a reaction, and people get all excited because some of my guys would run out and use at about 9 months, and it was because the trauma came out, and you just gotta roll with it.
Yeah, remember,
that kind of
when
pain.
people have all these problems, the medical problems and thinking problems and the money problems and all these other kinds of problems, sometimes it is a mask, and often it is a mask to not think about the trauma, because you're thinking about survival, okay? And trauma is not, once you've got your survival needs met, okay, 8 or 9 months, then the trauma can come out. But you have to realize you're going to treat them longer. You could be 5 years treating these folks, and that's okay. They got to have close supervision. They need to be constantly engaged. Be careful about your own reactions to them. You get frustrated with them. You can get over involved with them.
You should just copy and print out the little addition here. The chance that setbacks will happen 100%. Usefulness and pretending otherwise 0. It's going to happen. Always treat for malnutrition. Somebody asked about vitamins. Everybody who came to me basically had malnutrition. They've been living for years on super gulps and chips. They came to us, and they were often, they didn't know how to cook. They didn't know how to make a budget last. They didn't know how you eat regularly, or how to not drink 6 pots of coffee before you come into urine test, because that was the only way you could get a mild stimulant going, 6 pots of coffee to get to test, because we took away their stimulant. And they have acute vitamin deficiencies. And so you need to look for depression, work on exercises for memory, and address malnutrition. And people donate vitamins and stuff to you, and it just starts to address some of the acute deficiencies that have occurred sometimes over 20 years, where people have not been eating correctly, and they come to us with a host of problems. And part of it is they just need vitamins and minerals, man. I mean, they're just comorbid problems. They will have STD. You will expect trauma. You will expect prior sexual assault. You should look for hepatitis. It'll be there. All kinds of dental problems, all kinds of other problems. Stimulant prescriptions such as Adderall or Vinace for participants with meth use disorder. Good God. No.
No, absolutely no.
What if they already addressed with something else? If they've been diagnosed with ADHD or one of the deficit disorders, we have had some people do very well on the non-stimulant form, which I can't think of right now. It worked really well on one of my guys who was a really bad meth guy. And when he finally took that drug, he told me he felt normal. If I don't think about it, it'll come to me. Exercises for the brain. No, it's a non-stimulant treatment for Strattera. Thank you. It's Strattera. I had a couple guys do just amazing. It was like Dr. Jekyll and Mr. Hyde stuff, how fast the transformation went when they got on Strattera. It was amazing. But I don't try to throw stimulant flame on a stimulant fire. So again, I'm not a physician, but if I am working with a physician, I make sure that they understand methamphetamine and methamphetamine use disorder, because I learned many years ago that a lot of physicians have less than 2 or 3 hours of training on substance use disorders, and you're going to get half of that in this single training. So table tennis, eye-hand coordination. Interesting. You know, the guys who flip coins across their fingers, I could never do it, but there are people who do it. Simple math, playing music, all of those things restore areas of the brain. Exercise for the brain. Once the fog clears, my friend Alex Stalkup, who was one of the guys who validated the matrix model, I just loved it. Every March, he'd go out and buy exercise bikes that everybody was putting out in the front because they bought them in January and they don't use them. And when people got fidgety because of that stimulant, right, they'd want to leave group, and he'd put them on these bikes. You couldn't leave group, but you could pedal. And it was awesome. Walking groups, hiking groups. We had guys who walked across the Oroville Dam here, which is the largest landfill dam in the United States. And they were the dam walkers. And they did that every day. And they walked across the surface of the dam, a mile in each direction. And it was great for them. Hiking, swimming, gyms, yoga, whatever suits their interest. Once they stabilize and get past the clumsy thing, start getting those people moving. But not at first, because they'll break something. Exercise is a great adjunct. This is my favorite part of this whole presentation. In a treatment court model, you can expect success. You can take it to the bank if you're doing it right. And if you show these people that this is the right place for them, they will do better. And one of the favorite parts of working, you know, a lot of people, oh my God, methamphetamine. I tell you what, working with them is different. The level of denial is very different. I don't have people telling me, I don't have a problem. My problem is you guys and the judges and everybody you picked on, the dump truck public defender. I have none of that with people who are addicted to methamphetamine. They know exactly how sick they are. They are crabby and unpleasant at first, but they have been trying to feel less bad for a long time. And their gratitude for recovery is so profound when they actually find their way out of this hole. They are amazing to work with.
Yes, their brains
There.
can recover, okay? There's a normal brain sitting there over on the left side. You can see the reddish areas, the hot ones, then the yellowish, and then there's greenish. You look at the method of user, this is 1 month of abstinence, and you don't see any red in there, maybe a tiny bit of orange, but not a whole lot. You get them to 14 months of abstinence, and heck, it's looking a lot like the normal brain. Okay.
Yeah, well,
So,
the whole flow in the middle photograph, you can see the frontal lobes. I mean, that person is basically a squash. That person is truly ill. And if they're showing up in that first month or two, you have a win. It never seems like a win, but trust me, that's a freaking win. Those people are really bad a month or 2 months in. They're really bad. They're just trying to hang on, and you can reward them for hanging on. They do recover. There's the part that I really like. This is a marathon. It's not a sprint. It's not going to be an easy cure, but don't give up, and don't let them give up, because they actually do well. And we have a whole mess of citations and resources because Brian's a geek. Look at all that geeky stuff.
Great. That was really excellent. So if anyone, I know you were already answering some questions as they came up, but if anyone has questions, we have a few more minutes. If you want to throw them into the Q&A, we will take a look.
This is a miracle. We never get done early.
It was excellent. So
Get him, Brian.
So much good information.
You warned me, and so I was trying to be good.
There you are.
I'll just wait another second. Anybody have any questions? Otherwise,
It's kind of hard to work with these people because they seem so flat. And it seems like you're not getting anywhere, and you are. They're in there. I used to try to tell people they're in there. They just can't get out. They're behind this mask. They're in there. Don't give up. There's somebody in there. And eventually, if we do the right things, they'll come. And you sat on the bench with them, right, Judge? And I mean, they're sitting there and how are you today? And they're just, God, they're just so sick. And then all of a sudden the light starts to come on behind their eyes. And I see there's a person, and they're going to find their way out.
I think one of the things you said to me that helped me so much way back when was, if you tell somebody in a court session who is a methamphetamine user to do X, Y, and Z by the next session, they will forget it on their way out the door. And instead of us assuming it's intentional, it really is a brain problem. So that was incredibly helpful.
Yeah, it's not malice.
Right.
They're not even capable of malice.
You have to have capacity in your brain before you can have intention in your brain. If you don't have the neurons there, well, then you have no capacity. There's no intention because it's not there.
Yeah, it's like Oakland. There's no there.
Well, I think that's it. We just had one last comment that said, excellent job. They really loved the content. So thank you to everybody. And again, this will be,
there's another comment about how it's similar to working with TBI. Let me just say something about comparatively.
Oh, sure.
It is similar and it's not similar. Certainly the fact that the brain insult is enormous is similar. However, it is both harder at the beginning because of the holes in the brain, and it's easier at the end because the brain has been refilling and rebuilding itself. And with TBIs, if we have people who have TBIs that they've had, and they're not acute TBIs, but rather they have the effects of them chronically, it's much harder to rebuild the brain, honestly. It really is much harder.
Good stuff. Thanks, guys.
Thanks, everybody. This will be on our website if you need the recording.
Fun stuff.